we will move on, and it's my pleasure to introduce Mary Beth Hans. Again, Mary Beth is the clinical director of our BPREP program. I'm sure that many of you have had the opportunity to see her in the clinic. She's been a wonderful again, colleague and resource for patients for our program. And this morning, she's going to talk to us about the anatomy of a risk assessment. Why do we ask the questions that we do? Thank you, Mary Beth.
Okay, thank you. Thank you, Dr. King. And thank you to all of you for taking the time this morning to join us. What I'd like to review today is what kind of information we use to help women try to understand where they might fall in terms of risk for breast cancer, and how we use this information to devise appropriate screening and prevention strategies. As Dr. King mentioned, we see individuals in our program for a number of reasons, but what every visit has in common, though, is a breast cancer risk assessment. And so it's this aspect of the evaluation that I'd like to break down for you today. So this will look familiar to those of you who have been to our program, but even if you haven't, you have likely been asked these types of questions on other health intake forms in your provider's office or possibly at the time of your mammogram. So I think it's helpful to understand why we ask these specific questions and how the answers to these questions impacts your estimated risk. The information we are looking for falls under three main categories: hereditary, hormonal, and pathologic. In terms of hereditary factors, we are specifically interested in any family history of breast cancer, as well as other types of cancer. We need to know who in the family had the cancer and at what age they were diagnosed, and if any genetic testing has been done, and if so, what were the results. The hormonal questions that we ask relate to age at first period, any pregnancies, age at first birth. We ask questions about menopausal status, as well as a history of any hormone use. We would like to know if you've had any breast biopsies, and if so, what were the results? Were they completely benign, such as fibrocystic disease, or were they atypical in some way, specifically atypical ductal or lobular hyperplasia, or lobular carcinoma in situ? Additional factors we need to consider have to do with mammographic density and BMI, which is a weight for height measurement. There are other lifestyle factors that affect risk, but BMI is the only one that's actually a variable calculated into risk model estimates. And it's important to note also that age is one of the most significant risk factors for the development of breast cancer. Breast cancer risk increases with age, but the models also take into consideration the years lived without a breast cancer diagnosis, so the calculation will be different at different ages to reflect this. Providers in the BPREP program utilize what is known as NCCN guidelines to ensure we are practicing evidence-based medicine. NCCN stands for National Comprehensive Cancer Network, which is an alliance of 33 leading cancer centers devoted to patient care, research, and education. Some of the guidance provided around screening and prevention is suggested when specified thresholds of risk are met. The risk calculators we use help us to quantify risk so that we can more readily identify women who are appropriate for various screening and prevention options. There are several different risk calculators that we can use in our evaluation. Some models, like the BRCA Pro model, are used mainly to estimate the likelihood of having a BRCA mutation. The Gale model, which is available online, is used to estimate 5-year and lifetime risk for developing breast cancer. The family history component of this model takes into consideration the breast cancer history of only first-degree relatives, so mother, sister, daughter. The Tyrer-Cuzick model provides both the likelihood of having a BRCA mutation as well as 10-year and lifetime risk estimates. This model takes into consideration first and second-degree relatives, with the latest version now including breast density as a variable in the calculation. The 5-year calculation helps us identify women that have sufficient risk to warrant consideration of medication for prevention. Lifetime risk estimates are often used along with mammographic density to guide recommendations regarding the use of supplemental screening with breast MRI. It's important to understand these models have known limitations. They do not accurately consider racial, ethnic differences in incidence. The Gale model tends to underestimate risk in women with a particularly strong family history, while the Tyrer-Cuzick model can overestimate risk for women who have a history of a high-risk pathology. It's not infrequent that there can be significant range in the risk calculations between models for a given individual. And this highlights the importance of the BPREP clinician, as their expertise is needed to interpret these models and guide you appropriately. So now we'll just take a look at the risk factor elements in a little more detail, starting with family history. So having a family history of breast cancer increases one's risk, but there are specific cancer patterns in a family that additionally raise the possibility that a genetic mutation could be responsible. Now, most women who develop breast cancer do not have a strong family history of the disease, but we really don't want to miss these potential genetic families because the associated risks are much higher and the surveillance recommendations we make will be different. Features of a potential genetic predisposition are having multiple affected family members on the same side. And it's important to mention here that the father's family is just as significant as the mother's. Onset of cancer at an age younger than 50. Any male breast cancer is a red flag, as is the presence of additional types of cancer along with breast cancer in the family, such as ovarian, pancreatic, prostate, or melanoma. It's particularly suggestive if a single individual has had more than one type of cancer. Individuals who are of Eastern European Jewish or Ashkenazi ancestry have a higher risk of carrying a BRCA mutation. The incidence of BRCA mutations in the general population is approximately 1 in 400, where in the Ashkenazi population, the carrier frequency is 1 in 40. Therefore, our threshold for thinking about a BRCA mutation is lower in this population. If your provider thinks that genetic testing is indicated, it's important to know that this now routinely involves testing for multiple genes in addition to BRCA. This is known as panel testing, as we now recognize that there are several genes other than BRCA that can play a role in familial breast cancer. So moving on to hormonal risk factors, the younger a woman is at the time of her first period and the older she is at menopause will increase risk slightly, as the breast will be exposed to the cyclical hormonal influences for a longer time. Pregnancies are considered protective because it essentially represents a break from the cycling hormones. And although not calculated as a variable in the risk models, breastfeeding is considered protective. That's because once a cell has undergone its final maturation step, ready to perform the specific function of the tissue. So in the case of breast lactation, a mature cell is generally a more stable cell. Now, data gathered from many studies looking at hormonal contraception, primarily birth control pills, showed only a very modest increased risk during the time the pill is taken, and that risk returns to baseline 5 years after stopping. But it's the prolonged use of oral combined, so estrogen and progesterone, postmenopausal hormone replacement therapy, which is associated with increased risk. In contrast, women who are able to use estrogen-only postmenopausal hormone replacement therapy because they've had a prior hysterectomy do not experience an increased risk. Vaginal estrogens, either in the form of tablets, creams, or rings, are also not felt to increase risk. In terms of pathology risk factor, there are many benign changes that occur in the breast that do not increase the risk for breast cancer. However, some pathologies do have the ability to increase one's risk. Atypical ductal or lobular hyperplasia increases lifetime risk from the average of 12% to approximately 20%. Lobular carcinoma in situ increases the risk to approximately 25%. Having a history of one of these lesions, which we collectively refer to as high-risk lesions, increases risk to both breasts, slightly more so in the biopsy breast, and the risk is specifically for estrogen-driven or ER-positive breast cancer, so cancers that use estrogen as fuel to develop and grow. Having one of these atypical pathologies, however, provides us with a unique opportunity to reduce risk by using estrogen-blocking drugs such as tamoxifen for prevention. I mentioned that mammographic density is a variable we need to consider when assessing risk. This is not information that you are asked to provide on the questionnaire. It's something that we enter after reviewing your mammogram. When you have a mammogram, the radiologist must include a density classification, and they have one of 4 categories to choose from. Mammographic sensitivity decreases with increasing density. A developing mass will appear white on the film, so looking for a white density in a fatty gray breast, such as categories A and B, is much easier than trying to identify a white density in an extremely dense white background, as in category D. Extremely dense breast tissue is not only an issue in terms of potentially masking findings on the mammogram, we have data to support that extreme breast density is also an independent risk factor for the development of breast cancer. In other words, an extremely dense breast is a higher risk environment compared to a fatty breast. Fortunately, only about 10% of women fall into this density category, with the majority of women, 40% each, falling into categories B or C, and the remaining 10% in category A. We review lifestyle factors with all of our patients, as this can provide opportunities to discuss strategies that will contribute to a reduction in risk. Postmenopausal obesity is a significant risk factor for the development of breast cancer. And as we just heard in Dr. Ligabell's excellent talk, evidence supports that getting in some consistent, moderate level of activity can reduce risk. I think we all understand that smoking increases the risk of all cancers, including breast. In terms of alcohol, there are studies that can demonstrate an increased risk with as little as 2 drinks per week. However, we generally counsel a less is more approach when it comes to alcohol. Whenever you can make a different choice, try to make it, ultimately aiming for less than 3 to 5 drinks per week. Another factor I wanted to mention here because of its significant impact on risk is the history of prior radiation to the chest. The most common example of this we encounter is in a woman who has a history of receiving radiation to the center of the chest, known as mantle radiation, as a young adult as part of treatment for Hodgkin lymphoma. We start to see a real increase in risk approximately 8 years after completion of the radiation, with the estimated lifetime risk up to 30%. Given this risk, these women are advised to have supplemental screening with breast MRI at the 6-month interval following their annual mammography. This is also a scenario where we consider offering tamoxifen for risk reduction. So in order to appreciate how the factors we just reviewed ultimately impact risk, it's important to understand the difference between absolute risk and relative risk. Absolute risk is the chance of something happening to an individual over a particular period of time. Relative risk takes into consideration factors that may increase or decrease that risk. So if we say the average absolute risk for developing breast cancer over a lifetime is 12%, and take the example of consuming more than 1 alcoholic beverage a day, increasing risk by 20%, 20% of the average risk of 12 equals an additional 2%, bringing the total absolute risk to 14%. All of the questions and answers from the survey generate a report for us that looks like this. And we use this report to identify areas that affect risk and opportunities to address those risks. So looking at this example summary, at first glance, we note a family history of breast and pancreatic cancer, and that the woman indicated Ashkenazi Jewish ancestry. Now, there are no other breast cancers in the family. However, looking at the pedigree, we note that the patient's affected mother only had brothers. And so putting all of this together leads us to have some concern for a potential BRCA mutation. So we'll discuss referral to our genetics colleagues for consideration of testing. Next, we note that her BMI has tipped over into the obesity category, and that her alcohol consumption is a bit high and she's not currently exercising. And this gives us the opportunity to address lifestyle changes that can help reduce her risk. We look at the breast density in combination with her calculated risk, in order to address if we feel there would be a benefit to considering enhanced screening, such as with MRI or contrast-enhanced mammography. So in summary, I've tried to illustrate that breast cancer risk is multifactorial. Some of these factors, such as family history or breast density, are not in your control. And some factors, such as diet, exercise, and alcohol, we can try to change. It's really important to understand that the current risk models in use are imperfect and are not meant to label you as an individual with a certain risk level. Rather, these models are tools that help predict risk in a population of women, as they do not accurately discriminate between individual women. So if there were 100 women with a particular risk factor, the model can predict that X number of them will develop breast cancer, but not specifically predict which ones will or will not. I like to think of these models as providing a general sense of where one's risk lies and help to highlight where we have room to reduce that risk. And most importantly, there are efforts underway to devise a more accurate, individualized risk assessment, along with evolving screening strategies, so we can best match a surveillance prevention regimen that will be most effective for you personally. And this is a great segue into our next talk by Dr. Lehman, who's at the forefront of some of these very promising efforts. So thank you for your attention.
Thank you, Mary Beth. That was an excellent overview, some really important information there. As we know, we do our best to make sure that patients, providers are aware of our program and the opportunity for patients to come in and learn about their risk. One of our attendees asked what is being done to educate the PCPs and other providers out there in the community that may not have as much insight into these risk factors as we do. Do you want to speak a little bit about some of our outreach efforts? I mean, of course, this effort this morning is where, maybe there's a PCP on the line, but this is certainly something that we're focused on. Do you want to share some of our efforts with our group?
Sure. So we do a number of outreach to our clinician colleagues as well. We've visited GYN offices, jumped in on sort of monthly meetings with primary care groups. I've given some lectures to the PAs in primary care and GYN. We're working with our radiology colleagues, particularly to help sort of educate a little bit around breast density. There, even on the clinician level, there's some confusion about that and when to refer and when not. And we're always open for any kind of questions that they send to us. Along with referrals from patients that we can sort of try to let them know what kinds of things we do here and how they can help us and help their patients, and who's appropriate for referral.
Yes, absolutely. So anybody, again, who's joined us this morning, if you think that your primary care physician's office would be interested in hearing from us or having some of our materials for referral in their offices, please do let us know. You can email us, Olivia Papas, our coordinator, who's been emailing you. We'd be certainly happy to spread the word to get the information out there about educating all patients about risk and what they can do and how to get to us if they need to. We do have, again, wonderful colleagues here at the Brigham who help us manage side effects that often occur from the medications that we might recommend to reduce risk. Some of those, the menopausal side effects we know can be quite bothersome, and we do have, again, specialists here at the Brigham in the Menopause Health Clinic that can help manage those symptoms. Let's see if there's any other questions that have come in here. We're not going to have a talk specifically about medications to reduce risk this morning, but Mary Beth, do you want to say a few words about what those options for are and how we counsel women?
Yes, sure. So we speak a lot about medications for risk reduction, particularly in our population of women who have had these atypical breast pathologies. But some women with very strong family histories actually do meet the sort of risk threshold to be thinking about it. We talk about tamoxifen primarily. There are some additional choices postmenopausally, raloxifene and aromatase inhibitors. Tamoxifen recently has become a little bit more exciting for us in BPREP because we have now a low dose option that can be used pre or postmenopausally. But it's been a huge advance because a lot of women were fearful about 20 milligrams tamoxifen, tended to have more side effects with the 20 milligram tamoxifen. And now low dose tamoxifen, we can prescribe for just 3 years instead of 5 years. The side effect profile is not dissimilar to placebo. And there's also a nice carryover effect of risk reduction with the low dose tamoxifen that we do know exists with the full dose. So there's always new things being developed and looked at, and which is why we just continue the conversation every time when somebody comes. Sometimes patients won't be interested the first couple times we mention it, and then suddenly 3 or 4 years later they want to hear about it some more, and they're ready to give it a try. It's important to note that these are just options for risk reduction. We're not interested in sort of destroying the quality of someone's life over this. We have a low threshold for stopping if for whatever reason it doesn't agree with the patient. But when one meets the criteria for considering risk reduction, we do think it's a worthwhile effort to try and see if the medications can help bring your risk back down to baseline.
Great, thank you. And certainly, again, and if you have more questions about risk reduction medications or any of the other content from Mary Beth's talk, please do put those in the chat or send those in to us, and again, our goal is to provide you with the information that you need.